Hi, I'm Morse, the founder of Qualifications Training, and this is Campbell, a tutor on our Manual Therapy CPD short course. In this short video, we're going to demonstrate mobilisation techniques for the knee joint. I'm going to show flexion with abduction and adduction, extension with abduction and adduction, medial rotation, lateral rotation, patella distraction with medial and lateral glide, posterior to anterior using a pillow, and then using the belt. We can add on a physiological movement on top of the accessory. So first of all, we're going to perform the flexion with abduction and adduction. You can start off in this position for the lower grades, maybe 2 or 3. But if you are trying to perform a grade 4 and you're flexing and adducting, it may be that, as you can see, you're getting quite a lot of femoral rotation. So if that's the case, more of a supportive way of performing this movement is using your shoulder to support the knee, and then flex, and then add in some adduction here. So you have less rotation around the femur and more movement around the knee. So we're flexing and adducting, so moving the foot towards the midline, and then we're going to flex and abduct. It's not to say that you need to do both of these in one session. Depending on the test results, your assessment results, it will then determine which movements you do. And again, the assessment movement and what you're trying to achieve will determine which grade you use, 1, 2, 3 or 4, and whether you use abduction and adduction or just one of them. So for flexion and adduction, we flex and a smooth movement, bringing the foot in, using the lower leg as a bit of a lever, trying to create a little bit of adduction within the knee joint. For abduction, we're flexing and bringing the foot outwards towards you, supporting the knee and the femur with your shoulder and hand. Just make sure that it's not painful for the client when you're holding the lower leg. It may be that you hold higher up or slightly lower on the ankle joint. Just be careful you're not squeezing the malleolus or just above it on the soft tissue that can be quite sore. So that was flexion with abduction and adduction. For extension, ask the client to straighten their leg. So usually, if we were going to perform this within clinical setting, we would make sure the knee is pointing up to the ceiling and the leg is in a nice anatomical position. We would treat the leg closest to us, so it would look like this. However, for the sake of the video, we're going to I'm going to lean over to show the movement around the knee with the opposite one. So the hand position is still the same. We still have it above the knee. And then, as you would in your test positioning, your range of movement in active, passive, resisted, and extension, positioning is the same. And we can extend with a slight bias again to abduction and adduction. So with abduction, we're going to bring the foot up and then out slightly. So if the client relaxes, should be able to have a little bit of passive movement there, so you can see the heel lift off the ground. So assessment movement first, make sure that's okay. Does that feel okay? Mm-hmm. And again, just make sure the pressure around the knee is okay. So use the fleshy part of the leg, not the bony prominences around the knee joint. So extension and abduction, moving the heel up and away from you in a nice C-like movement. And for extension with adduction, we're going to just move the lower leg towards the midline. So again, making sure there isn't any lateral rotation or medial rotation. We've got a nice line between the ankle, the knee and the hip. The clients can relax, and then we're going to just extend and bring the lower leg up and in. This will increase extension. This is a physiological movement. And again, we're still thinking about the different grades. So if you watched any of the other videos, grade 1 and grade 2, reduce pain. Grade 3 and grade 4, increased range of movement. You've got the small oscillation for grade 1, the larger oscillation for grade 2, a large oscillation for grade 3, and this is where you might get to the end of range, and then grade 4 is where you stay in the end of range, and that's a small oscillation. So that was extension with abduction and adduction.
While the client's in supine, we can medially rotate and laterally rotate the femur, which will have an effect obviously on the tibial joint, the knee joint. We need to get the soft tissue out of the way. So scoop the gastrocnemius and the soleus out the way, using the shoulder as we did with the last manoeuvre. And we're going to laterally rotate. So we're going to bring the lower leg out towards us. Trying to make our hands as big as possible, support the whole leg, and we're going to rotate around the knee. So you should probably see that the foot just rotates out as well. So a grade 4 might look like this. Small oscillation right at the end of range. There's not much bounce. Grade 3 is a larger oscillation with more bounce as we just hit the end of range and come back out. So this would be for a stiff knee that we're trying to increase range of movement. This is the accessory movement, medial and lateral rotation. Medial rotation, again, want the soft tissue out of the way, and then we're going to rotate the tibia and the fibula medially towards the centre of the body. We want to make sure we get rid of the soft tissue because we don't want to be doing this. This is just moving the muscle, not the bone. So think about the bone and then feel for that range at the knee and then perform your movement then. 3 times 60 oscillations is a usual place to start until you feel a change. And you can move through the grades. So that was lateral and medial rotation of the knee. For the patella, we can glide it laterally and medially. So just with your thumbs, making sure the leg's straight. If the knee's flexed, so if you've got it on a bolster or a pillow, the patella will sit within the groove and there won't be much movement. So there should be a nice amount of movement in your patella. So you should be able to move it medially and laterally. And you could even compare from the other side as well on the other side. To perform the movement, if you're going to turn it into a mobilisation, your assessment movement as well is important. And then just gently using the pads of your thumb, you're just pushing the patella away from you. Or using your fingers, bring the patella towards you. So your hands are splayed, supporting the rest of the leg. So we're not moving all of the leg, we're specifically moving the patella. If you pop your fingers in a triangle type shape, fingers and thumb, to try and distract the patella, you have to tuck your fingers underneath the bones. So you've got the patella here, you could just fit underneath. So gently squeeze through the soft tissue, cross the fingers, and then just squeeze and try and lift the patella up. It's good to ask permission before you start wiggling the kneecap, playing with the patella, because sometimes the clients can be a little bit squeamish. For posterior to anterior movement, we can use the pillow and then we can use the belt as well to start to layer those accessories and the physiological movements together. So if you'd like to lie onto your front, please. We can use a pillow to get a little bit of flexion. You can put both under there if you want. Put that on there. So PA, the posterior to anterior is the movement. We're going from the posterior aspect of the body and we're pushing the force towards the anterior. So here we've got a little bit of flexion, so we can glide the tibia along the bottom of the fibula. So you want an anterior translation of the tibia. Our hands just above the joint line, and again, feel through that soft tissue. Remember the popliteal fossa is an area of consideration, so we're not going to press on the fleshy part or the crease. Make sure you're below. You can use the ankle as a bit of a lever. Test movement first. Does that feel okay? Yep. And then again, you might have a grade 2, which again, if you've watched any of the other videos, you probably know it off by heart. That is going to be a large oscillation. But remember, we're not near end of range, so we shouldn't feel the resistance. We're using the VA scale, visual analog scale, so the client can give you a number out of 10 to describe their pain or their sensation, and you can work with that. These should all be relatively pain-free. So as you move from grade 2 into grade 3, another test movement. Does that feel okay still? So grade 3, we're just feeling a little bit of resistance, and we can perform another set of movement here. It may be that we don't move on to grade 4, it may be too painful. So there's a small movement, not a massive amount to see, but the client should feel it around their knee. So if the client says that it hurts or they feel anything, always ask specifically where they feel it. And ask them, can they actually feel the movement around the knee? Tell them what you're aiming to achieve, and they'll be able to tell you whether your hand positioning is right. And again, just be careful of your grip around your lower leg. This is just resting here. You don't need to squeeze the lower leg. The leg's just resting on, just for you to create a little bit of a lever if you need to. I'm going to just take the pillow away. So now we can use the belt. So we can form the PA, posterior to anterior movement, with a belt. You lift your leg. I'll show you on this side. It might be a little bit clearer on the camera. So the belt goes around you and the client, and again at close to the joint line, just avoiding the popliteal fossa there, and using the ankle again as a lever. Nice and low, depending on the height of your couch. So you want the angle, the pressure is going to be coming from you as you pull the belt, and you want to have an anterior translation again of the tibia. So just reduce any excessive lateral or medial rotation of the tibia, and then we're going to lean in. You can probably see a nice movement here around the knee. So that's PA, posterior to anterior movement. Does that feel okay? Mm-hmm. If it's pinching the client or they don't like it, you can pop a towel, a folded up bit of couch roll or something. It may be that it's pinching slightly, or if you've got it slightly twisted, so if it's tight on one side, slack on another, it's going to pull some of the soft tissue around, which might be uncomfortable. So as you're pulling, just make sure it's even on both sides. And then perform your desired grade. So 2, 3, 4. You can decrease. If you decrease the flexion, just make sure you either raise the couch or you lower down, just so we are gliding that tibia. Think about the force and the angle at which the belt is at in relation to the leg. Making sure your chest is up and your posture is good. You don't want to be hunched over. The mobilisation will be more effective with a good posture. You can, like with other mobilisations we perform with the belt, you can sustain the PA and then you can add in some flexion. This can be really helpful for anybody with very swollen knees that just swell quite a lot. It's been useful for runners in the past that have had some generic knee pain. Maybe some of their tests have come back, when you've performed tests on them, they've come back stiff or reduced range of movement. Perform the PA with flexion, can help increase range of movement. So here you're trying to sustain that PA movement while you then deliver a physiological mobilisation on top of it. Lower the leg back down. All of these techniques are covered in our manual therapy short course. To find out more, please visit www.coreelements.uk.com. Thank you. Don't forget to subscribe.